I think I hit
the.
Oh, there it goes. Okay, so welcome everybody to the Asia Pacific Community Call. Today's Asia Pacific Community Call. So we are actually honored to have two professors with us who are actually going to be talking about their papers after I provide a little bit of a community update. So today's theme is really network research and OMOP projects. Okay, so that's what our theme is today. I do want to provide, before we go into there, provide you a little bit of an update from what's going on in OHDSI as a whole. So there's quite a bit that's going on in the last 2 weeks. You can see here in the OHDSI Community Call, there's actually 6 different presentations that was presented yesterday on 6 different network research, and I believe they're all active. And I believe we have one of the presenters here who might want to have a shout out to, join his study, right? So Chan, you want to give a little bit about what you presented?
So I presented the preliminary literature from my recent study, which is investigating the cancer risk between H2 blockers, including the ranitidine or Zantac. You may know that that drug was recalled from the market because of presence of the carcinogen, and I wanted to make sure that if there is a increased cancer risk in users of ranitidine in the real world. So if you are interested in this study, please let me know and join this study. This study will be closed soon, so please grab the chance. Thanks.
So if anyone wants to participate in this study, reach out to Chan. Okay, you can find him on OHDSI, you can find him on OHDSI, and you can find him on OHDSI. And there is another study that's going on that I will bring up 2 weeks from now, but if you guys have an interest, so the Pioneer Study-a-thon just finished, and they are actually looking for Asia Pacific participant in the study-a-thon that they did. I don't have the details for that yet, so that's why I can't give you any more information than that, but it is on cancer, and I can't remember which cancer. But they will
prostate
give me
cancer.
All that. I thought it was prostate, but I didn't want to say the wrong one, right? But they will give me all that information, and I'll present it to you guys in the next community call. So, but if you have an interest, let me know, and I'll connect you to the Pioneer folks, okay? They really, really would love to get Asia Pacific to participate in their study as well, okay? But as you can see, we actually have a bunch of papers that actually was submitted and published in journals as well. And I think this one, from the looks of it, it's like an entire fully Korean team, correct? So
right.
Congratulations on that one, right? Whoa, go Korea. You guys are publishing like crazy here. Because I remember seeing you guys again last week as well in a bunch of publications as well over here. So Chan, another one right there that you published in the Journal of Hypertension. So Chan's just publishing a lot of papers. So again, if you guys have an interest in any of that, you can go there. Last week also, the video that they showed, I don't know if you guys remember, Patrick was talking about there was a competition, well, not a competition, but a challenge, a March challenge on showing COVID visualization. So last week what they did is took all those visualization and kind of showcased what all the different people did and what the stories were behind their visualization. So if you guys have an interest, go ahead and go there and play those, okay? So those are the 2 meetings that taken place. Now for the Asia Pacific side, we don't have a date yet, but there is a I want to call it OMOP-a-thon, DOC-a-thon, ETL-a-thon. We haven't come up with the actual name for it yet, but we are in the community planning something on the Asia Pacific side to get all the Asia Pacific folks in a room, virtual room, or if you guys within the country, so you guys can get in a room, to go over like what is the whole ETL process to do an OMOP conversion, right? And to document that, so that everybody here on the Asia Pacific side can share that knowledge, as well as understand what some of the challenges are and understand what some of the solutions are out there in that space, okay? Last but not least, that's been going on in the community. Last week, they had the OMOP CDM working group had a special session to talk about what to do with V6 as well as what to do with some of the changes that has been asked for. Okay, so there was a vote. It was during your nap time or your sleeping time, really. So, but they've already come up with a bunch of things that they want to do, as well as some that they're not going to work on. So the current path is actually to not continue V6, is to actually kind of put it on its side and actually introduce a 5.4. Okay, we've finished up what the details are, but we're now writing up a more descriptive summary of what all the different changes are, and it'll happen in the next week or so. So when that's available, I will review it with everyone here, and we can have a discussion about that. So it'll be one of the presentations that we do, so that you guys can talk about it, because they would like to make sure Asia Pacific is on the same page, as well as Asia Pacific agrees with those changes. And if you guys have any, challenges to one of those changes, then we can take it back to the other side. Okay, so look out for that. Probably in the next APAC community call, we'll be talking about that. Okay, we do have two professors, so I will let the two professors do a quick introduction before they go into their presentations. So the first one, we have Professor Lu. She's here. She's from Yale University, and I know for sure it's 11 p.m. her time. So Professor Lu, you want to give a little brief introduction of yourself?
Hi, everyone. Good morning and good evening, everyone. My name is Yuan. I am an assistant professor at Yale School of Medicine in the section of cardiovascular medicine. I was trained in public health, in cardiovascular epidemiology, and global health. I did my PhD in Harvard School of Public Health, focused on cardiovascular risk factors, analyzing different population survey data, and then look at the disease burden associated with different risk factors. I came to Yale after I graduated from my PhD, did the postdoc, and then transitioned as a junior faculty. My recent research interest really transitioned to clinical informatics and connected this with population health and implementation science. So it's really a nice opportunity, and I feel a great honor to be able to work with OHDSI team and MUI and all the other data partners on this project, focused on hypertension and trying to compare different second-line antihypertensive agents using the data sets from the Asian Pacific country. And I think this is particularly relevant in this region, as it accounting for nearly half of the cardiovascular disease in the world, and also is the home for nearly half of the population with hypertension in the world. So thank you for having me here to present the result of our study.
Thank you. So we also have Professor Hong, who's here for the first time as well.
Yeah, thank you for inviting me to this great meeting, and I'm a beginner of this OHDSI meeting and CDM. Thanks for Chan. He introduced me all these things and he let me know about this. So this is the beginning of the journey. Our team just started a national funded project to capture the epidemiology of rare endocrine disease, which I majored in. So the endocrine disorders, rare endocrine disorders are really problematic because we don't have enough information about that, which is becoming a huge barrier for developing new interventions or diagnostic modalities. So I'm very interested in how can we utilize this informative tool in the field of rare disease, not the common prevalent disease. So with the presentation of mine, which has been video recorded, I'd like to ask the opinions and comments and any advices from you expertise. Thank you.
Awesome, thank you. With that, I'll first turn it over to Professor Lu to do her presentation first.
Okay, should I share my screen?
Yes, if you could.
Okay, let's see.
It's the three little It's the little box with the arrow up. Oh, there you go. Perfect.
Can you see that?
Yes, we see it. Yeah, we do, but not in the slideshow.
Yeah, let me do that. Let's see.
At the bottom.
Yep, bear with me 1 second.
Yep.
Okay, so this is a study using the OHDSI APAC network dataset and compare the effectiveness and safety of second-line antihypertensive agent in the world. And so it's trying to utilize the legend principles to mobilize the collaboration in the OHDSI APAC network. And this is the first collaboration in the network, and I'm looking forward to have more collaborating projects. So first, I just want to thank all the collaborators from different countries and institutions. This is really a true teamwork. Without all these people's input, it's not really possible to conduct any of this study. And this presentation has been presented in the OHDSI APAC Symposium last year. But here, what I want to focus is really the updated result since last December. And I just want to highlight the importance of hypertension in Asia. So in 2015, there are about 1 billion adults in the world have hypertension, and nearly half of these people live in Asia Pacific countries. This region accounted for about 60% of the total population in the world, and it's the region with the largest population of hypertension in the world. So as we show here on the graph, showing the trends of prevalence of hypertension from the last 4 decades, since 1975 to 2015, there's a large increase in prevalence of hypertension in Asian region. And this is mainly due to the change of the age structure as population is aging, and also the size of the population in this region is really large. So as we expect the population continue to age, the prevalence of hypertension is going to increase, and the associated burden of cardiovascular disease is going to increase as well. So really, it becomes a major public health issue in this region, and it would be it would be our responsibility to address this major epidemic in Asia Pacific countries. So just want to quickly go through this. This is a study as an extension of the Hypertension Legend Initiative. So in 2019, the Hypertension Legend study published a landmark paper in Lancet looking at comparative effectiveness of the first-line antihypertensive agents across different databases of the world. Here, we want to build on this Lancet paper, and we want to develop a large-scale observational study that provide comparison of the dual combinations of 4 major antihypertensive drug classes for treatment escalation. Here, the key is treatment escalation. When we look at the literature, we found that about 70% of the patients with hypertension, blood pressure control goal cannot be achieved by monotherapy. That means if you give patient one drug, it's not enough to reduce their blood pressure to the control target. And what is currently recommended in the guideline is to use what is called a step care treatment. So you add a second drug, and then you add a third drug until the blood pressure reduced to the target. There are so many antihypertensive agents out there, but there's no really explicit recommendation from the guideline of which agent should be the most effective one, or the most safe, or the safer one as the second agent added after monotherapy. So it's really a good question for doing observational study to compare different effectiveness of this drug. Major issue is that there's a lack of evidence from the clinical trial. I want to mention there's only one major trial called Accomplish, has compared two drug classes together, but they only restricted to a few agents. and then they restricted to very small population subgroups, not looking at population variation across different countries and variation by age, gender, or history of cardiovascular disease has not been explored. So there's a big room for improvement in this area. Study aim, our aim, this study actually has 3 aims. The first aim is descriptive. We want to describe, just to characterize what is the pattern of antihypertensive agent use among patients with hypertension. Second aim is to trying to look at comparative effectiveness of different agents. And the third aim is focus on safety outcome. So here I want to present the most updated result for aim 1, which is trying to test the feasibility of using the EHR data in Asia Pacific countries to describe real-world utilization of dual antihypertensive combination therapies for treatment escalation. We look at the overall population, and we also explore variations by subgroups of age, sex, history of cardiovascular disease, and country. So even this is a descriptive aims, it represents a tremendous effort. Like I only started to work on EHR data since maybe 2019, and I didn't realize there's so much work need to went into this just to define the cohort, to clean up the data, to harmonize the variable, etc. So EHR data, real world data is really messy compared to like the past data I work on, population health survey data, cohort data. These may be much more clean. So I just want to recognize and acknowledge all the work went into this by our collaborators. You may already familiar with this. Here we use the active comparator new user cohort design. This is the recommended study design for comparative effectiveness analysis. And as I mentioned before, we modeled this study on the previous Legend Hypertension Lancet paper. Matai Shumi and others has published a paper in 2020 to summarize the 10 guiding principles of Legend. So here, I think this is a nice visualization of the 10 guiding principles to guide researchers from defining the research questions up until dissemination of the finding. So really systematic methodology to define a process of high quality observational research. So I think this is really nice process. And just some my personal thinking is that like JAMA and some other top medical journal, when they talk about clinical trial, they still consider as the gold standard. And when they talk about observational study, they think all observational study is, is secondary. You cannot provide any deep insight using observational study. But really, what is wrong with observational study? Observational study also have high quality and low quality. If we conduct it in a high quality way, it will still provide deep insight in the field. Like what is considered as the high quality observational study? I think the Legend principle really summarized that in a nice way. And it's really good for us to learn through all these guiding principles and conduct a study to follow these guiding principles. Here we define 12 exposure cohort because we focus on 4 different drug classes: ACE inhibitor, ARBs, calcium channel blocker, diuretic, and beta blockers. So we want to generate the cohort that exhausts all the different combinations of these drug classes. So as you see, these represent 12 exposure cohort. First one such as ACE inhibitors or ARBs, and then the second drug is calcium channel blocker. And then the second drug, the second cohort would be the other way around. First drug is calcium channel blockers, and the second drug is ACE inhibitors and ARBs. We want to look at the patterns of use of all these 12 drug class combinations to see what is the distribution look like in different countries. And within each countries, what does the distribution look like by age, gender, history of cardiovascular disease, and other characteristics. So we used the ALICE to develop the cohort definition based on the open science principle of legend. So we post all these ALICE cohort link online, and everyone can check that to see how we define this cohort. Based on this 12 cohort, we construct a comparison. Each of the target cohort will be compared to the comparator cohorts. One thing I want to highlight is that for each comparison, the first drug is the same, if you notice. And then it's really, the second drug is different. So we want to compare what would be the, it's related to the research question, what would be the most efficient, effectiveness, and safe second drug added after monotherapy. So we want to keep the first drug the same. Outcome, we use pretty consistent outcome as the Lancet hypertension paper. There are 3 primary outcomes using the 2017 American Heart Association and American Cardiology College of Cardiology guidelines. And these 3 outcomes include ectomyo infarction, hospitalization for heart failure and stroke, and 6 secondary outcomes included here, mainly cardiovascular event, different type of stroke, heart failure, secondary, sudden cardiac death, or unstable angina. And we also consider 46 safety outcomes. And all the phenotype definition already available in the link here. In the first aims is purely descriptive. This outcome has not been integrated yet, but it's more for the future 2 or 3 aims when we conduct propensity score and trying to compare the effectiveness and safety of different agents. So let me show you the committed data partner here. Let's see. Yeah, so we have data source from 5 countries or regions, have from Australia, Korea, Singapore, China, and Taiwan. They are at different phases. Phase 1 result is ready for the first 4 countries, and Taiwan is still collecting characterization and treatment pathway result. I think I'm missing one slide here. Maybe I delete that. I should have a slide showing each of the different database here. And then just want to mention all the database cover 21 million patients altogether, and all of them are EHR database. And then this is the number of cohort, number of patient counts in each of the exposure cohort of different database. So you can see that just by looking at this, we color coded. Thanks for Jing and Xialing. The first impression by looking at this is there is a large variation in drug utilization across countries and across different cohorts. For example, looking in Australia, the most common drug use combination is ACE and ARBs plus calcium channel blocker. And the second one, like calcium channel blocker and ACE inhibitor and ARBs. Since cohort 1 and cohort 2 are pretty consistent, it's the most common drug combination used across all the countries and database. However, some of these drugs, like CCB plus beta blocker, is rarely used in Australia, but is quite commonly used in Korea and Singapore. And it's also rarely used in China in the Jiangsu hospital, but also like commonly used in Taiwan. So I think this will be related to the practice pattern in different countries, and also maybe the clinical guideline implemented in each country. Really interesting to see how this varies by different countries and database. And then we look at the drug utilization by gender. The the gender ratio of hypertension is 1:1. Interestingly, what we identify is something is consistent across different bases is that women are more likely to be in cohort number 4, which is diuretic plus ACE inhibitors or ARBs. Cohort number 8, diuretic plus CCB, and cohort number 12, beta blocker plus diuretics compared with men. And interestingly, this finding is consistently across all the 8 databases here. I think we show 7 here, but actually we have 8 databases. So interesting. And then we look at how the distribution vary by age. The majority of cohort 1, of patient in cohort 1, which is ACE or ARBs plus CCB, and in cohort 3, ACE, ARBs plus diuretics are in age 45 to 64. And many of these patients in cohort number 7, number 9, number 10 involve CCB, diuretics, and beta blocker are in the older age group, in age greater than 65. And the drug utilization in Australia and Singapore is higher in the age greater than 65, whereas in Korea it's higher in the middle age, in 45 to 64. So there's substantial variation in terms of drug use by age. Then how about by history of CVD? History of CVD is denoted as color of blue here. So you can see it's relatively small proportion of patients with hypertension have history of CVD. The majority of these patients have no history of CVD. But among the patients with history of CVD, cohort number 5, ACE and ARBs plus beta blocker. Number 6, beta blocker plus ACE and ARBs are the most prevalent ones. This is consistent with the guideline for secondary prevention of CVD. So when you look into the guideline, it was suggested for those who have established CVD, they should prescribe ACE and ARBs or beta blocker for reducing the risk of cardiovascular event. So it's great to see in the real world evidence, people are following the guideline, and really these drug classes are most prescribed in patients with history of CVD. Then we look at the treatment pathway. The treatment pathway will provide information on the order of the drug prescription. We select here, we just show the biggest data set in each of these countries, like in Australia, LPT database. We can see here the purple, the pink one, showing ACE and ARBs as the first line treatment. Is the most common first line treatment among patients with hypertension. And then the pink plus the orange one is the ACE and ARBs plus CCB, is the most common 2 drug combination used. This is consistent with what we just saw in the descriptive table previously. But it's showing more in a nice visualization way to look at the order. And then when you look at Korea, let's see, so the orange and the red one is the most common one, like calcium channel blocker and ACE and ARBs are the most common one. And it looks like a different pattern, just by first impression. It's very different pattern compared to the Australian database. And then look at Singapore. It's very different too. Like many people on only 1 drug, you can see. Not many people are having more than 2 or 3 drugs. And then in China, in Jiangsu. So just to summarize this, you can see by just looking at the color, the shape of the graph, there is a significant variation in drug utilization across country. The most common first-line therapy in patients in Australia and Singapore is in ACE and ARBs. But then when you look at Korean patients, the most common first-line therapy is calcium channel blocker. And then it seems Australian patients have more patients on second-line treatment than those in the Korea patient. And most patients in China initiate calcium channel blockers or ACE and ARBs, and those two drug classes are the most commonly prescribed classes on the treatment pathway. So that's the current updated result from the first aim. It's purely descriptive. We are working on a manuscript to summarize this finding. As I mentioned, even just descriptive result, it represents a huge amount of work. I want to especially thank Jing, Mui, and Xialing from the IQVIA group to coordinate all this effort. So if you want to join this study and have questions, feel free to contact me and Jing. So we have the email address here, and really welcome for your comments, inputs on that. So I'm working on the manuscript, and we expect to have the first draft to be shared with all the co-authors and data partners in the next couple weeks. Looking forward to input. Yeah, so there's some of the appendix I will not show here, just for the sake of time.
Awesome. Thank you, Professor Lu. Any questions from anyone? I see a lot of hand clapping.
Thank you.
Okay.
This is also my first experience with OHDSI. So I'm still a beginner and trying to learn, keep up with you guys. It's really a good learning experience for me too.
It's keeping up with Professor Yu over there. That's who you got to keep up with.
He's a superstar.
Or Nicole in Australia. It's keeping up with those two. Okay, so if you guys have no more questions, again, if you're still willing, have data in the Asia Pacific and would like to join the study, let us know. We will also include you. It's not too late, like Professor Yu says. It's not too late yet, but we will close it soon as well on our end. So, okay.